Brandy went to the bathroom.
Okay. This next exam will include 5 math, and there will be 3 skills. Those skills you have so far is ID. So you can expect if I said something twice yesterday, you will have it. You need to, relative to skills, you will need to know complications of iron therapy, remember, and I'll go into this in the concept blending too, but you know that there are certain complications, such as iron therapy, there can be phlebitis, and I described what that was and what you need to do that occurs. There's thrombophlebitis, and there's fluid overload, and those will be named infiltration. So you need to know the signs and symptoms of that and what you need to do. Also, relative to IV, you would also need to know fluids, generically speaking. If something was isotonic, and I told you, you're working a lot, no one say them. If something was hypotonic, or something was hypertonic. I'm not getting into fluid and electrolyte balance and all that. It's you just need to know what those fluids would do.
Less than 3 years at hypotonic,
right? Anything with dextrose and sodium with a higher percentage of each of those is going to be hyper.
55 is hyper.
Hyper. A5 monosaline. Yeah.
But D5 in water, whatever, that's hyper, right? D5W.
The percentage, yeah, the percentage of molecules. And so you will find that, I would say go back to your action in block 1, but also in that the readings relative to ID. So that's 8 questions. Math and also curriculum skills. Now the math, you know it's going to be algebra, rates. And then at the end of class today, I will do one of those miles per kilogram, an easy one. You're not in that level yet, but any math you have can be absolutely performed. And anything I put on a test, a math problem, I or Professor Bethune will have worked it on the board and elicited questions from you. No hidden agenda. That leaves 42 questions. Not 42. Yes, it is.
Yeah.
Yeah, 42. And that will come from Professor Bethune's lecture. And today, reason why I have this grid is to kind of bring things together and tell you what will be inclusive of the exam. Now, when I present the lecture, I'm going to say these are some of the things that may precipitate the disorder to occur. But you see where it says to be covered in class? Those are symptoms. Symptoms will cover in class and any treatment. So there's a PowerPoint on the disorders.
Do you have this stuff anywhere?
It's in all four.
The PowerPoint's in the very bottom.
Current PowerPoint, like red or whatever. Now you notice we will be covering anemias, and I'm going to tell you right now, don't freak, you'll see there's a lot of them, but most of them have the same symptoms and what you do about it, except for specific to certain meds, dietary. We'll go with that. Yes?
For the exam, do we need to know, like, okay, for example, like troponin, we know if there's high levels of troponin, then, you know, they probably had a myocardial infarction. But do we need to know, like, the normal levels of
Lab
troponin?
values?
Yes.
No.
We do not.
We do not say, oh, this person comes in with potassium, this, that, and another. We
Okay,
want you to know what to do
okay,
based on what you see and what you assess
okay.
about the patient.
So you just need to know
In
this
other
high,
words,
you need to look
yeah.
for this.
In other words, relative to blood components when they do a phlebotomy, if I say this person has lost blood, you know the hemoglobin is inadequate.
Right.
We're not getting into values.
Okay, good.
So don't be studying values.
Okay, good to know.
Know that they exist, and you know from last semester the highs and lows. Question.
Because Professor Bethune had covered, well, it's on our cardio PowerPoint, that
Oh, you need to know that.
all of them. Yeah,
Learn it by groups.
basically the people that.
And let me just take the time to tell y'all the down and dirty.
Just the ones we went over in class.
What you went over in class, groups. If you know one from that group, you pretty much know what all of it is. For example, I'm gonna take the time to show you how that applies. You've just administered nitroglycerin sublingual to your patient. What would you expect, knowing the properties of nitro? What would you expect the vitals to be of this patient
Before.
after you give it? What is the therapeutic effect of nitro?
Lowers their blood pressure.
Decreases workload. So you might have a question of choose all that apply to this next, which is lowering of the blood pressure, decreasing cardiac workload, patient may experience headache after, okay, and increased confusion. All of that applies, but there's going to be some that don't apply. All right. So we're going to be covering, back to where I was going, the different anemias. There's always an oddball, and we're going to talk about that oddball. Pernicious anemia. And also sickle cell. Okay. Then leukocytes. We're going to talk about leukemia when we talk about cancer. So don't, when you see this grid, don't think of leukemia as being presented on this exam. It will be covered when we talk about cancer. But we'll kind of get a gist of what your leukocytes do. Platelets. We'll talk about that disorder. You're around enough platelets, you're going to see certain things on that patient. Hemophilia also. Okay, and then next Tuesday, I'll go over some of the venous and arterial type disorders. Also on the exam, I'll ask a question or two about blood and clotting factors. But the clotting factors are going to be in relation to clotting factors and vitamin K, fluid, all of these things are going to be in regards to clotting factors. What is analyzed in lab in relation to the med given. I will have one question on blood. That's why I make this grid. You can get moved.
Oh,
In other words, I'm saying, this grid is saying, if you have a donor, the person's type, well, donor, person's type, what can they get? What can they receive? And we'll talk about a term of universal recipient versus universal donor. That'll follow. This exam is geared on not little isolated fluff. It's geared on needs to know relative to if you took care of an anemic patient, for instance. What would you see in that patient unless they had a different type of, like, pernicious anemia, which we'll talk about? What would you see in that patient and what would you do? You'll find commonalities as I present today, that you don't need to know everything about those disorders, but what collectively is that being said, I'm just gonna, in regards to this grid, how it will help you. Because one semester I had this grid up and the student said, you have the grid, but there wasn't one question on the grid. I said, excuse me? We went over these disorders. So basically, when we talk about the disorders, there is a PowerPoint, and it's blood disorders. Should I? It is trying to hematological problems. There's also PowerPoint that we're going over today. It talks about assessment of hematologic system. This one is like a review. You've had A&P. You've had, in block 1, lab values. And again, no lab values on the test. But as I talk about the disorders, I'll relate it back to this problem. So that's just a review. With that, let's talk about hematological. We'll talk about anemia. Okay. Reduction in either the number of red blood cells, the amount of hemoglobin, or hematocrit, for whatever reason. Sometimes we have a reduction in the red blood cells because a bone marrow is not synthesizing or producing those red blood cells, which are the erythrocytes. Same with hemoglobin. If you're not producing enough of red blood cells, the hemoglobin levels or iron carrying capacity of those red blood cells is going to be low. And that's the number of circulating red blood cells. And even though you may have the increased amount of circulating red blood cells, but the morphology is not conducive to you having that increased oxygen carrying capacity. We're going to talk about a disorder called sickle cell anemia. Clinical signs are not, if someone has hypoxia, that's a symptom of a disorder. If someone has fatigue, that's a symptom of a disorder. So, rule of thumb with anemia, there's two things you're going to see common to all anemia: fatigue and some degree of hypoxia. Be it from not enough being produced to the morphology is not conducive to having the oxygen carrying capacity. With that being said, if I had anemia, let's go back to our grid here. Aplastic anemia. That means my bone marrow is not producing enough or almost nil my red blood cells. It could be as a result of chemotherapy, like radiation, the actual meds, chemo. Certain meds will cause a reduction in the production of the red blood cells. So someone on chemo, the reason why, someone who has cancer, they're getting chemo, the reason why they may have the anemia is because the chemical agents, the radiation, has decreased the production of red blood cells. That's why they're anemic. Around here, they do crop dusting. Insecticides can cause a change in the bone marrow production of your blood cells. So, that person is going to have fatigue, shortness of breath. There may even be, if you don't have enough circulating red blood cells, what's going to be the color of your skin?
Pale.
Pale. How did you know I was pale? Where is a good place?
Your eye.
The mucous membranes, and the conjunctiva and the mucous membranes. Pale. If I don't have enough oxygen over time, what color would my mucous membranes change? Some degree of cyanosis. That's a late sign. Cyanosis is a late sign. So again, aplastic, the causative agent is as a result of the bone marrow has had a reduction in the production of the red blood cells, usually associated with some type of chemical agent or radiation. Again, won't you see the patient? Anything that shows that they're hypoxic, anything that shows that they're fatigued. So starting from the head down, what might be my medication if I do not have enough red blood cells? We want to start with anxiety. That's the first. I'm just saying. And anxiety is not my personality, so it doesn't fit my personality. Now, going from anxiousness, what might they do later on? Confused. I feel confused sometimes, but more than my norm. Okay, what you already said, the mucous membranes, the conjunctiva, and the oral mucosa is going to be pale. Okay. What temperature would be my skin?
Cool.
Cool or cold? Either one, depending on the degree of reduction. What might you already said pallor, the paleness. If I do not have enough red blood cells, what would be my breathing status?
You'd have high respiration.
Breathe faster. I'm tachypnic. Okay. And when I get somewhere to my resting place and short of breath, what would you hear in my mouth? Huh? Not maybe.
Maybe
You know, I don't know. You might hear wheezing if I'm trying. You might hear some wheezing. Everything's working faster. What about my heart rate? The heart's trying to kick in to get more blood throughout the body, more oxygen. What might you notice about degree of muscle movement and what have you? I'm fatigued. So what would I do? Lethargic. Very lethargic. Would it affect my pulses? If I didn't have the volume of blood, because you need the volume to fill the abdomen. Okay. Now let's talk about folic acid anemia. Folic acid is what vitamin
E.
Folic acid and anemia. What foods make you high in folic acid? Folic acid, you're looking at almond, nuts, whole grains. Okay. So, if someone's deficient in that, they may present with some type of fatigue. Okay. Also, folic acid is, people can have it as a result of malabsorption. Individuals who've had multiple surgeries where they have the short gut supposed to be, where they don't have the absorption of the folic acid they're taking in. So that can be dietary. There's also drugs or pharmacological agents that decrease the amount of absorption of folic acid. Anyone on oral contraceptives and anticonvulsants as a group. What it does, it decreases the effectiveness, the efficacy. You'll hear it farm. It decreases, it's an antagonist. It decreases the effectiveness of the absorption of folic acid. So far, this is how you need to be thinking a question like that. Relative to aplastic anemia and folic acid anemia, what are some commonalities that you would see in both these? Fatigue. Knowing specifically that a patient has aplastic anemia versus folic acid, which one is which of the anemias dietary is not the prominent correlated? All right, iron deficiency anemia.
So I'm sorry, our main symptom for folic acid anemia is fatigue, that's all.
Fatigue, okay, the difference, you would have fatigue, would you have shortness of breath with folic acid?
Yeah, you're still deficient.
But which one would have more prominence? Aplastic. But they're not gonna be hard like that. I'm giving you some simple ones. The ones they do concept of it would be prominent.
So the symptoms are pretty similar.
Yes.
This aplastic is more anemic.
Right. Iron deficiency.
So we go over the treatments or no?
Treatments. Okay, what would you do if someone comes to you with folic acid anemia? What dietary things would you do?
You get vitamins, folic acid.
Supplemental vitamins, but if you don't always give them that, what foods would you increase in their diet? You said it.
Whole grains.
Grains. Okay. Okay, let me do another question I might be asked. Let's say female's taking oral contraceptives. She comes in with fatigue. She says that she's been working the night shift and she hasn't been able to eat as she used to. They do a full folate level and she's low. She says she's taking oral contraceptives, she's taking this. And I might list several meds. What would, and I might ask the question, what may have been a precipitant of her not absorbing folic acid? Contraceptives. Now, let's move to iron deficiency anemia. Gender-based, who's more prominent to have iron deficiency? Female. Because they have that almighty monthly cycle. They call it thirst and flow to everything else. That happens. In conjunction with that, if they're a teenager, they love to eat what their friends eat, not always high in iron. Eating McDonald's every day is not all that high in iron. There's a lot of fat and everything else. But what are some foods that are high in iron besides meat?
Spinach.
Liver is the almighty gains the iron. Spinach. What else? What if they're a vegetarian? Green leafy vegetables, huh? That's green. So I'll say it again. High in iron. Not a person vegetarian. They can have beans, legumes, green leafy, what? Well, I'm going to tell you something that'll go through all nurses. Green leafy. Okay. So, what would you teach a patient? Here's how a question might be asked. You've taught your patient relative to they have a disorder of iron deficiency anemia. What food choices made by the patient would alert you to the fact that they understood your teaching. You would find, hopefully, green leafy, liver is high in iron, legumes or beans. However, it could be asked another way. What in the diet, what choices of the following, if a patient chose, would indicate they needed more teaching? If red meats, green leafy, your beans are not on there, but you have other things like, it could be anything from, it could be anything that is not in that group, but it might be something like French fries. Okay, you know it's not going to be high in iron. You're going to say that the patient, if they chose this, then they eat every day. That would be an indication. So questions are going to be geared at, what would you know the patient understood by the choices? Or what would you know the patient did not understand? So iron deficient diet. What individuals are more prone to by demographics prone to iron deficiency? Areas of low social-economic status. Because last I checked, green leafy, your red meats, expensive. What's a inexpensive meat? Grounded.
Shoot, even that's
I
expensive
heard it.
now.
Some type of poultry. In some places, that's expensive. Okay, so you could say chicken. What else could they get iron from? Beans. Most people can afford beans. Chronic alcoholism, a behavior that is modifiable that can attribute to iron deficiency anemia because of the synthesis of iron. Alcoholism interferes with the synthesis of iron. So, if you have a question on the exam that says, what modifiable behavior that a patient may exhibit could attribute to iron deficiency? Alcoholism. There are some people who have had numerous surgeries. You know these people who have that gastric bypass or any of those things for weight reduction? They have a problem with the reduction of iron. The same thing if they have part of the stomach removed. So GI relative to the absorption, and if they have part of the stomach. Why are pregnant women prone to
The baby gets it first.
they may have the volume, but who are they trying to, the cells and that baby in utero. So pregnancy, the iron levels are low. Adolescence because of the rapid growth, males and females, but predominantly females. Okay, and some infective processes that cause iron deficiency. Okay, pernicious anemia. Someone who has had multiple gastric or just GI surgeries where the intrinsic factor, vitamin B12, is intrinsic. It's inside the body that's causing the anemia. this individual's not absorbing enough vitamin B12. That being said, go ahead, ask your question.
I'm just wondering what the symptoms are.
Oh, okay, excuse me. Get me on track. Iron deficiency anemia, needs to know, okay? Someone does not have enough iron, it's been verified by lab. Their ferritin levels, their iron binding capacity, all of that. They don't have enough iron. What are some routes for getting iron into this person? Oral.
Green leafy.
Diet itself. The green leafy again, and the meats, okay, red meats. But let's say that person, the diet's not enough. You may have to give them PO iron, ferrous sulfate. You may have to get, I'll remember that.
Iron.
Okay. You may have to give them the iron IM. And you may have to do it by IV route. Let me answer your question.
Is there such thing as, like, I don't know, I think really be overdosing, but, you know, taking iron and then getting sick from it, like your heart
Yes, you
rate
can.
goes up and.
Yes, you can.
Okay.
Too much iron. Okay. Iron, PO, needs to know. Needs to know. I said it twice. Okay. If someone takes oral iron, if it's in liquid form, it stains the teeth. If it's in PO form, the side effects of it are, they may have stools that look tarry, but there's not any blood in it. Black tarry stools can occur as a result of taking PO iron or liquid iron.
Doesn't it cause constipation?
Constipation, nausea. I said it again, nausea. You would alert the person to they may have tarry black stool. They may also
Sure.
staining of the teeth. That being said, with the oral, what would be pertinent, as a nurse is doing discharge teaching on a patient going home on iron, oral, what are some things that you need the patient to be alerted to that can occur with this? Okay, they may have constipation. They may have nausea. And they may have a tarry stool. A question could be asked this way. A patient presents to you and says, ever since I've been taking this iron tablet, I've been having tarry stools. Patient didn't tell you that they forgot what their discharge instructions are, but nevertheless, they come to you and say, I've been having tarry stools. What would you advise that patient?
Normal.
What would be your suggestion?
But this is normal.
This is normal, but in conjunction to that, if they don't tell you anything about blood loss or anything like that, that would be in the stem, you could say it's correlated as a side effect. What could you encourage them to do if they do have constipation?
Drink more water.
Water, not Diet Coke.
Okay, water.
Okay.
Walk around, have activity. If it's constipation, fluid fiber, activity, and eating foods that might have a little roughage. Yeah. Okay. Now, if they're getting the iron IM, what root of iron, what type of iron did you get? Did you guys hear about the track?
Mm-hmm.
Okay, the patient may ask you, why are you doing that injection different than what I've got all my other injections? Your response would be, for deeper absorption of that med, since it is irritating to the skin, you have to get it removed. Because iron is very irritating to the dermis. So you want to give it Z-Track. And Z-Track is you just place the skin and you stick down your needle, you give your med, when you're through with the med, you let the skin displace back. And that med is at different levels. It's in the dermis, it's in the adipose area, in the muscle where you go. Rapid iron deficiency is your pregnancy, I gotta say it again, pregnancy, adolescence, and the process. Let me throw another question out to you. You are working an adolescent unit, a 15-year-old female who is, a 15-year-old female who's already went through puberty, still growing, still having growth, says to you, I don't know what happens, but every time my iron levels are low, what might have been, what might be the correlated rationale for her low iron? The monthly menses, and just because of the rapid growth during adolescence.
You're athletic, right? You tend to have a low iron.
Huh?
Extremely like athletic. You have tend to have a low iron too.
Because there's rapid muscular
Muscle.
growth. Yeah. Okay, here's the oddball. Pernicious anemia. Yeah, they have the lethargy. They may even have lethargy and fatigue. They may feel like they're short of breath because the heart's trying to help them because they're fatigued. But pernicious anemia affects the nerves. That being said, the person presents with paresthesia. What is that? Numbing to the extremities. And sometimes it can affect the cephalic area, just the head in general, where they have like a little tingling. Tingling anywhere, the paresthesia is associated with pernicious anemia because the person lacks the absorption of vitamin B12. You already told me what foods you would have them take. Okay. You also, let me go around the question. Patient presents to you 2 years prior they had a gastric bypass or they had a condition where part of their GI system was removed. Patient presents to you and says, and every time I walk, I feel this tingling in my leg. I must say, of the following anemias, what one is more correlated with why this person's having a pernicious anemia? What are we going to do about it? If someone has pernicious anemia, they need, since they don't have that intrinsic factor, they need injections of vitamin B12 for life.
B12 for life, you
Yep.
said?
Usually every 3 months or something like that. But, so, a question could be asked. A person with known pernicious anemia says, will I ever have, I'm tired of getting these injections. Will I ever be relieved of this? No. No. You wouldn't say no. You would say,
Hell no.
you need this for life so that you will have a factor called intrinsic, which is produced in the GI tract for you to be not getting yes.
That's only to be when they're missing the intrinsic factor.
Yes.
But if it's dietary, because like they're a vegetarian and they don't
Yes.
have the injections, they
Dietary is modifiable. But if with the diet, a lot of times, the people have absorption problems anyway. So dietary, they may need to supplement a vitamin. Question.
So, would you say that the pernicious anemia would be more extreme than the first one of them?
No, they all extreme.
So it, like all
But
the signs,
pernicious is different than any of the others because of the neural involved.
but that patient would still just have fatigue and maybe like trouble breathing and stuff.
Because with the teeth, what happens is, it's a nerve conduction thing. So all of our body needs nerve innervation. So they may be fatigued because they may not get the nerve in. Because of parasitic question.
I always thought anemia meant iron, but really what just means low red blood cell count.
Okay, anemia
Just in
can
general.
be iron deficiency.
But it's not always.
It's not always, because
Okay.
a person can have a lot of red blood cells, the erythrocytes circulating, but the iron carrying capacity of the erythrocytes is not high. So there could be that. So you can have someone who may have a hematocrit that is in the norm range, but their hemoglobin is low.
I have two questions. With the intrinsic factor with older people, isn't there something in the intestines with them, like you can't absorb it as well when you get older?
Yes, thank you. With elderly, age-related, elderly lose a certain degree of an intrinsic factor. And their GI absorption in the first place, absorption and motility. So with elderly, you'll have a higher incidence of iron deficiency anemia. Question here.
So, because their absorption isn't happening, that's why they can't take PO. They have to have injections. Because
Reason
if-
why elderly get the injection a lot of times, because you want that more rapid absorption that an injection would give.
But
And
if,
if they took it orally, if they have an absorption problem.
It's not going to get absorbed anyway.
yeah.
Uh-huh.
So that because if you don't have the intrinsic factor, how are you supposed to metabolize the vitamin B12
Right,
without? So that's why they have to do it.
alright.
Iron.
So the elderly are predisposed to iron deficiency
Yes,
and
and think about
pernicious?
the elderly. They, I didn't put the elderly on there, but what do these elderly people, well, not these widows, they're in every restaurant. But anyway, iron deficiency anemia in general, think of someone who may live alone. Are they gonna buy these expensive meats? Are they gonna take time to make them a pot of beans? And a lot of times they eat things that just make them feel like they're eating something. For example, I don't know if you have experienced any of these elderly that get the meals on wheels. You know, it's through the city, Meals on Wheels, where meals are delivered to their home. I've looked at those meals. I've tasted those meals. I come home and say, what's your not a lot of meat. Meat's expensive. When they do have meat, a small portion of meat and a lot of pasta. They do give them salads, things like that. It's supposed to be nutritionally sound, but we live in a society where that we want to serve the elderly, but the nutritional value may not always be that it should. Another question might be asked relative to iron deficiency anemia, relative to the elderly. We already said the absorption factor. Now I'm going to develop a question based on what Rob said. Not for you, but the thing is, what about the elderly and changes that occur with the elderly that would predispose them to needing IM injection for iron? They have that absorption problem. They have this motility. Okay, they need it for life, vitamin B12. If it's a dietary thing, they sometimes need supplement. And what are your sources of vitamin B12? Meats. And here again, vegetarian beans. And I asked you, I told you, it can be asked, how would you know the patient understood your teaching on diet? How would you know if they didn't? As a nurse, it could be asked, how would you, let's see, what would you instruct this person will need to do for life, or maintain for life? That is getting serial B12 levels and taking B12 for life. Iron. Well, it'll probably be iron. Okay. Let's move on to sickle cell. What ethnicities would be more peaceful? African American and some European ethnicities, but highly correlated with African American. It is a genetic disorder, meaning familial. It's autosomal. If a couple comes in and they have a child that's been determined to have sickle cell and will want some symptoms, and they say, we're ready for our other children, and they ask you that we might have, and they say to you, we're concerned about having another child that has sickle cell. What is your first response? Would you say, oh, let me just tell you about it. You think I have it.
Genetic testing?
You're not the one to tell them. You refer them to genetic testing. It's so easy. Oh, you're not that expert. You need to refer them to genetic testing. And yes, there is a higher incidence if you have one child and you have other children that have sickle cell. Now, what's the problem with sickle cell? In the bone marrow, when the erythrocytes are being formed, they become sickle. You would say, but there's a problem because the oxygen carrying capacity and the iron carrying capacity is low. It becomes even a more problem when those sickle cells come together or aggregate together. They can become a clot, a thrombus. They can occlude blood flow, decreasing perfusion. And if that perfusion is continued through time, they can have avascular, meaning no vascular, leading to avascular necrosis, avascular necrosis, meaning that the extremity or major organ, it has decreased perfusion as a result of the thrombus. Now, let me tell you some things that will precipitate someone going into where more sickle cells are produced. In other words, what precipitates? Change in weather from warm to cold. Cold weather. Sickle cell individuals have a problem during this season, colder weather, because they're trying to breathe, they don't have enough oxygen, and your bone marrow is trying to compensate or help by putting out more sickle cells. They don't need more sickle cells. They need the healthy, but they don't have it. So these people have all these circulating sickled cells of the erythrocytes. They clump together. And heaven help if the person is not hydrated, because you don't have the volume so those cells can move freely across each other. So, colder weather, dehydration, stress, 3 Ds. Colder weather, dehydration, and stress will precipitate crises where more red blood cells that are sickle are produced in the bloodstream. That being said, what do you think we need to do with these people when they come to the hospital and they say I'm cramping, their heart's just beating real fast, they may have a dysrhythmia? The first thing we're going to do is, you can give them some oxygen, but that oxygen
Or an
is
IV.
fluids. You need to hydrate them. Before they ever got in the hospital, and let's say you need to elicit how much fluid they've been taking at home, you need to ask them. And the goal is that you encourage them to drink anywhere from 3 to 4 liters a day. Well, what is a gallon of water? How many milliliters?
It's full.
How many milliliters is a gallon of water? 3,000. Yeah.
So they want to drink double what normal? Because is it normal 1 to 2 liters?
Uh-huh.
So they want to drink double that.
Yeah.
Okay.
Is that right?
Just a liquid or just water?
Liquid. Say if they're at home. Even though they're in the hospital now, and you're going to have that IV giving them a increased volume of hydration. If they're at home, use it as a teachable, when they go home, use it as a teachable moment when you're hydrating them through the IV route. You need to say, how much fluids were you drinking at home? And a question might be asked. Upon discharge from the hospital, what would you encourage a patient to do when there's a change in temperature? When there is stress? They need to hydrate themselves. Okay? And your target might be double the norm. What? 3 to 4 liters. With these individuals, when they're hospitalized, you want to hydrate them. You also want to give them oxygen, supplemental oxygen. You want to help them with that pain. Morphine is our friend. So, you give them hydration, you give them supplemental too, and you give them pain, analgesic.
Their whole body hurts?
They're aching. Just think, if you're not getting oxygen to your blood to area, your cramped blood, you're not getting other nutrients to that area also. So that being said, let's look at a sickle cell person. What might their mentation be if they're hospitalized, comes to UAB? They might, depending on the degree of sickling, they may have anxiety. But if they're in this chronically, and let's say they don't come to the hospital and it just exacerbates that word you heard in your steel, your charts, they may come in and anyway, the thing is, they're sickling and what have you. What did I say last? Anxiety. Okay. Anxiety. They may have some confusion. Okay. What would you do if they do have the anxiety and confusion? What do you do with any patient that's having anxiety? Give them some oxygen. 2 liters initially. What else? A question.
No, not a question. Just something to add to sickle cell. Most of these persons with sickle cell, sometimes we don't think they're in pain, but they have a very high pain threshold. So if you've been a sickler since birth, they may not exhibit some of the same non-pain cues that you're used to. Sometimes they can just be silent or they'll just rock. They get a little agitated, a little irritated. As care providers, you really need to understand the disease. Most times these persons are labeled as drug seekers. That's not true. Sickle cell is real. The pain is very, very real. Do we have some who have been conditioned to the system? Yeah. but that doesn't mean you don't treat them any differently. You do all the same interventions. Can they work your nerves? Yes. But still, you are there to care for their condition, not, I guess this is one of those times you really need to check your personal morals, your values, your biases, and just do what you need to do. Because a lot of them don't seek treatment before the crisis gets too bad because they don't want to put up with the attitudes of us. And we're supposed to be there to care for them. And I know Professor Denson was saying about African Americans, but you have some Hispanics, some Mediterraneans, persons of descent that can also have sickle cell. So that's just something you guys think about.
Now, I have taken care of ones who were drug seekers. And what threw him into crisis was he had sickle cell, he was born with, of course. The thing about it, what brought him to the hospital was not the temperature changes in the weather. He'd tell you, I drank a 40. And I said, at first, my green days, I said, what's a 40? Anyway, he drank the 40, and he followed it up with some shots or something, he said. And then also, he was a smoker, and I'm not talking about this regular Marl, any of the cigarettes. He came in and he reeked Mary Jane. Okay, how does the vasoconstriction from the Mary Jane? Dehydration from that 40 and whatever else he took. And he comes in and he demanded care. It's not the norm, as she said. It was his norm. The thing is, we do the same thing with him. We hydrate him, and I have a port. I said, and he get hydrated that way because his veins over time from multiple hospitalizations become sclerosed. So we had a port attack. We hydrate, give him meds. His form of meds was a PCA, patient control. Until we caught on, and we start saying, initially in the first day or two, we will have you on PCA. From there, we're going to work on getting you home, so we're going to go to oral. He was one of our repeat offenders. Quite often did it, because he knew that we was in the weather. It wasn't weather, it was his behavior. Okay, so again, what is our focus with these people? Hydration, oxygenation, pain management. And you want to keep them from infective process because they don't have that optimum circulation. Okay, one last one before we go on break. Polycythemia, too many red blood cells. Too many red blood cells, the erythrocytes. It can be familial. People have. So if I have too many circulating red blood cells and you don't have the volume, they're not hydrated, what might they be? Those red blood cells can aggregate together and become a thrombus. People with polycythemia, due to the viscosity of their blood, too much of these erythrocytes, they're high risk for CVA and MI. CVA and MI because of the increased correlation of a thrombus form. Also, people with polycythemia, you tell me what's going to occur to them with them. If they go from being here in Pasadena to it, and they go to the mountains, what's going to happen to them? They're going to have more difficulty breathing. So if they're going to have difficulty breathing, what would you tell them to do? Take rest periods, hydrate.
Why would these people have the difficulty breathing if they have so many red blood cells?
They have so many, but
They're not having a correlation with them.
Also with polycythemia, sometimes there's so many of these red blood cells in the site that they have to have a phlebotomy where blood is removed. They're producing. These aren't the people that you'll give them a dinner of liver and spinach. You don't want them to produce all these red blood cells.
So,
They don't need it.
so are they actually functioning red blood cells, or are they?
They're functioning, but there's too many of them.
Okay.
And reason why I mentioned about going to the mountains, hopefully it's cooler in the mountains. What's going to happen to that vessel? Constrict. They're going to, the heart's going to be beating faster to help them. Compensatory.
So does that have to deal with the erythro?
Oh,
Yeah, from the kidney.
Yeah.
Is that what's?
the erythropoietin from the kidneys signals the body when you're low in red blood cells. Kidneys expedite the erythropoietin, and when we get to renal, we'll see that they give those people who are in renal insufficiency or in stage renal erythropoietin for the production. These people don't need it.
Would high altitude affect anybody with any kind of anemia? Just these people are so anemic?
Okay, if someone is anemic, let me answer her question. Someone's anemic, they don't have enough red blood cells for the thus they don't have the oxygen, or enough oxygen, or the iron. They're trying to go, they're in a higher incline. How's the air there anyway? Huh? Then they have to breathe faster. They don't have the supply.
Any person with any kind of
Yeah. But these peeps, they're gonna have constriction and their blood is thicker. It becomes thick. Okay, let's take a break.